Start. I don't think sir will be joining. Hello?
Yeah, sure. We can start.
Yeah. Thank you, sir. Good afternoon, friends. It's Friday afternoon, and we are back with another one of our episodes of Forefront of Future Frontiers, the medical webinar series, which is being organized by the Scientific Society of Arupadavidu Medical College, a constituent college of Vinayaka Mission Research Foundation. And we are indeed very happy and proud to welcome you to the 98th episode of this consecutive weekly webinar series. And we are currently in series 15. We are exploring trends in medical education. We explored some topics on simulation, like how we can use non-technical skills and teamwork can be taught and assist in skill simulation. That was the talk last week. We had a talk on how we can use evidence-based simulation. And so these are some of the topics we had explored in this particular thing. So we'll move to a little different facet of the recent trends. And we are actually fortunate to have the team from AIMST, Professor KRS and Dr. Srikumar, who are willing to share their experience on modified MiniCEX for clinical skills assessment. And this was indeed actually short paper which they presented in the national conference we conducted, and it was quite an impressive experience. So we requested Professor KRS whether he is willing to share this experience with the audience, the FFF platform. So that is how this talk came about. And before we move further, can I request Dr. Deepa, who is the president of the Scientific Society, to introduce the speakers and welcome the gathering. Over to you, Dr. Deepa.
Thank you, ma'am. We are, as madam has told, we are towards our 100th episode. It's my pleasure to introduce our well-known personality among our AVMC faculty forum and students, Dr. KRS Sir, popular by the name Professor K.R. Sethuraman Sir. He is Dean, Faculty of Medicine, AIMST University, Malaysia. We have one more resource person from AIMST University, Malaysia. He is a Deputy Dean and Faculty of Medicine, Dr. Srikumar S.P. Srikumar Sir. He is with us. He is a renowned personality in the medical education, and he has done many publications, and he had been resource person in many national conferences and CMEs, and he had organized many CMEs and faculty workshops in the field of medical education. And indeed, it is an important topic which he will be discussing with us, modified MiniCEX for clinical skills assessment. And I thank our madam for helping me introduce, giving me this opportunity to introduce our resource persons today. Over to Professor K.R. Sethuraman sir with your introduction.
Yeah, thank you, Deepa. Before we hand over to sir, some few housekeeping announcements. One is we would like to inform the participants that this program is going live on YouTube and is also being recorded so that we could use it posteriorly for academic purposes. And the other information we want to request our participants to do is that please mute yourself so that the audio quality is good for everyone concerned. And other information we would like to share is that we would like to project a 15-second video of what we have done so far marching towards 100. Can you please share the video, Shiva? Thank you, Shiva. Over to Professor KRS for the introductory part of the talk. Sir, you would be the host now. You can actually share the screen, sir.
I hope the screen is visible.
Yes, sir. Good to go, sir.
Okay. Yeah. My job is to introduce in the next 10 to 15 minutes why should we think of going beyond objective structured clinical examination or ASCII for short, to split component Mini-CEX, Mini Clinical Evaluation Exercise. And then how we did it to conduct final year examination for the batch that passed out in December 2020 and 2021. That was masterminded and arranged by Dr. Srikumar with my assistant. So he will present the details. He was the chief coordinator of those examinations. And so now, first of all, Dr. Geeta, Dr. Deepa, MiniCEX is pronounced not as Mini-CEX, especially if a male. If I had to say that, somebody will put my name in Me Too in the afternoon. So let us be very clear, just like ASCII is produced with hard C, ASCII, not ASCII. This also is MiniCEX and not Mini-CEX, okay? So with that, I'll go to history of MiniCEX. As you know, American board was using oral examination in 1972 and replaced it with clinical evaluation exercise, which is a full-length long case given to a student for 2 hours, on which high-stakes pass or fail decision used to be taken. It was tedious, subjective, and not reliable, and was ruled out for a high-stakes examination in the US by a Supreme Court order in the 80s, because one student challenged. He was a very good student who happened to get a tough case and lost it. And therefore, they said it's totally unreliable, and it was banned. And then it was replaced by ASCII. But you know the shortcomings of ASCII in mini-stakes exam, high-stakes examination to get a holistic view of the clinical skills. So in 1995, the miniature form of clinical evaluation exercise was called as MiniCEX, was described by Norsini et al. The paper is available on the net, adopted by American Board of Internal Medicine, ABIM first, and later others as a better alternative to traditional long case exam and the piecemeal ASCII, which tests only component skills and not in a holistic manner. Unlike ASCII, MiniCEX permits evaluators to interact with the examinee and grade their performance. So it allows bedside viva in a flexible manner, which is not the feature of ASCII, where the station assessor has to just keep ticking the checklist or rating scale. So the strengths are it's doable, easy, efficient. We could do 100 students per day, as will be explained by Srikumar later. It is not possible to have a throughput of 100 students by any other method of examination other than ASCII or modified multi-station MiniCEX. Operationalizes assessment as in a standard format that every student gets a fair deal. And you can use real-world clinical setting in MiniCEX, which is difficult in ASCII, and more organized than just a clinical performance assessment or piecemeal version done in ASCII. The weaknesses is if it is too unstructured, and too vague, then the findings of assessment will be less helpful and valid. And many stations are required to make it reproducible. So they recommend for continuous assessment over 3 years, 12 to 14 encounters in 3 years of internal medicine training. And they said even 4 to 6 are acceptable, and they give reliable and reproducible rating. And how we planned and conducted MiniCEX, we used ADDIE model. When the COVID came, what happened is in Malaysia, all private colleges use government hospitals for teaching. We don't have our own hospital. And because of COVID pandemic, the whole hospitals were closed for anything other than COVID, and students were barred from entry. So we had to teach in real world setting, but in actual simulated manner. So how do we do that? So we have a big clinical skills laboratory, which some of you have visited. So we just oriented our clinical teachers to use Dale's cone of experience and choose what is most feasible. That is, as you can see, the bottom most is the most effective method, direct purposeful experience. And Sorry, direct purposeful experience is the most effective, but not possible in COVID times. So then contrived experience in skills lab, dramatized experience like role play, then demonstrations by professors on standardized patients, and then otherwise television, video, YouTube video, etc. were shown, and of course handouts. So the least effective but most feasible thing was symbolic experience, learning through verbal symbols or visual symbols, that is text and pictures. But iconic experience, learning through observation, is slightly better, that is videos. Direct purposeful experience is the most effective. That is the simplified principle of Dale's cone of experience. And the clinical faculty was oriented to this, and we gave freedom for them to choose to go as low to as high, means to number one, it's a direct purposeful experience as possible. If not, when not possible, replace with the second level or third level of priorities. Okay, so that was the ADDIE models, the A part. Then we chose one-on-one or two-on-one exam. That means faculty staff one or two with one student at a time in a station. And the clinical scenario could be outpatient, inpatient, emergency room, operating room, or field, depending on the subject. Like community medicine chose simulated field experience. In medicine, they chose inpatient for a week. They made a longitudinal 1 week, which Professor Y.D. Singh presented also in the ICON conference. And resources, as I said, they chose using the Dale's cone, what is feasible. Then the focus was on the clinical skills, history, physical exam, diagnostic reasoning, management. And the exam process, which Srikumar's focus was to be efficient, efficiency oriented, and based on single or multi-station as the need arises. Okay, so that was what was told. And then we moved on and we adopted the American Board of Internal Medicine, ABIM's MiniCEX assessment form, which is a standardized one, complexity, that is done by the person who organizes the case, whether you want a low complexity, moderate, or high complexity. And the focus is it on data gathering, diagnosis, treatment, or counseling, depending on the station. So history will be data gathering, physical examination is data gathering, then diagnosis, of course, then laboratory finding station, again on diagnosis, and the last one was therapy, counseling, on prognosis, etc. So this is how the progression was done in simulation lab. And accordingly, the interviewing skill rating out of 1 to 9, superior, satisfactory, and satisfactory. Physical exam skill, professionalism, clinical judgment, counseling skills, organization and efficiency, and the overall clinical competence. Organization and efficiency means the way the student summarizes the case and presents it efficiency, and also is efficiency and organization and planning a diagnostic process and a treatment protocol for the given case situation. Okay, so that's probably more important at a PG level, not so important for undergraduate level. Then evaluator overall global marking of evaluator satisfaction with that particular station Mini-CEX. And comments, we didn't have any residents satisfaction, we only took the evaluator satisfaction and the comments. Any other comments? So in a multi-station Mini-CEX, only the relevant, the whole form couldn't be used. Whichever was the relevant part, the planner of the particular station, medicine, surgery, pediatrics, OG, ortho, and they could choose psychiatry, which part is to be assessed. Then our plan for a hybrid Mini-CEX multi-station combining OSCE also was Are we going to do product assessment or performance assessment? That means whether the candidate's performance also has to be observed or only the summary whether the person has diagnosed correctly or chose the correct treatment, etc., which can be done offline also. So performance assessment was done in a simulation mode, ASCII, and with the examiner, 1 or 2 examiners observing in a simulated workplace was MiniCEX. Then only product assessment was also there, where there is no need to have an inspector, assessor, evaluate the response. Like the candidate elicits history with a standardized patient, then sees a mannequin which produces the lung sound or heart murmur, etc. Then in the third station, they write the summary of the case and put their diagnosis. And that is corrected later. That is only product assessment, not the process assessment. Later, case presentation and defending the diagnosis is done live. Again, they go to performance assessment mode with 2 examiners. Like that, it was a mix and match creatively done by each of the examiners and each of the subject specialists. But we gave 2 options, which is flexible again. Long case format was minimum 2 stations, maximum 5 stations. Medicine and pediatric had 5 stations, I think, whereas ONG opted for 2 stations. It was, it could be 7 minutes or 14 minutes. I'll explain why 7 and 14. So the total time was minimum of 28 minutes per case or maximum of 35 per long case. ONG and surgery was 28 minutes. Medicine and pediatric was 35 minutes. Average station time was 7. We duplicated 14-minute stations to make average station time of 7 minutes. I'll again explain why it has to be done. Most people will say put a rest station. That doesn't solve the problem. And each subject unit, medicine, surgery, ONG, pediatrics, orthopedic, were given freedom to fine-tune. And for short case, psychiatry was also added. So 1 station to 3 stations, 7 to 14 minutes per station. Total time was minimum 14, maximum 21. Average station time again 7 minutes. So that means 14-minute stations were duplicated to make 7-minute average. Academic freedom to fine-tune what is actually tested. And Dale's cone of experience again was our backbone to fit in. The 7 minutes was decided after 2 weeks of pilot study with that batch of students who appeared in December 2020. It was a learning trial for them as well as for us also. And we found that 10 minutes was too long and 5 minutes was too short. And 7 minutes was optimum for the kind of assessment we did. And in the ADDIE model, development, implement, and evaluate, DIE. So that was given over to the respective unit heads and the unit team. Analysis and design was my the dean's and the deputy dean's mandate, which we did thus, and we handed over. And why rest station was added, I'll just take a minute. This is not a 7-minute station, but let's say a 5-minute station as done in India. And there is a 1 to station 9 is 5-minute station. Station 10 alone is 10-minute station. So most of the educators feel if you put a rest station, the problem is solved. It is not solved because at the end of 10th bell, for example, all the stations 1 to 9 would have finished their candidates and they will be going out to drink tea. Whereas station, the 10 inspector or assessor will be the poor guy with 5 more person waiting. And it will take 100 minutes. The examination will go on for 100 minutes for station 10 and only 50 minutes for the rest of the stations. So, and then there will be in the so-called rest seat, there will be 5 of them talking to each other, which is very difficult to manage. So this is not a solution. This is a hypothetical solution, a myth created by educators, and it is still going on because I think Harden got it wrong in the beginning and no one has the out of respect for him, nobody corrects him. And so we have to have a average station time concept. That means whenever the time is double, you duplicate it so that the average time will be 5 minutes for all others. So when you do like that, you see 10A and 10B is here in this. So in that case, the first bell, candidate 10 will start the Viva, and then after 2 bells, 8, 6, 4, 2 will come. 10B will be vacant during the first bell, but from the second bell, ninth odd number candidates will go to B, 9, 7, 5, 3, 1, like that. So in 55 minutes, the test is over. In contrast to 100 minutes, if you just put a rest station. So this is a very important concept which we had to explain to our staff so that everybody was on board, especially and we had an army of facilitators who were moving the students. So they should know when to move the person from A, when to move the person from B and all that, so that we don't make any errors further in that. So this was done. And faculty, of course, rose to the challenge. We have an excellent team of 100, more than 100 faculty there. About 75% are from India, and then others are from Asian subcontinent and Malaysia. So it is not what you know, it is what you do that matters. So that was the philosophy. So we somehow did what we needed to do after a intense 2-week trial of hybrid MiniCEX ASCII for students, in which we learned as much as the students. We learned the processes, students learned the medicine component. And in medicine, surgery, OG, pediatrics, and orthopedic, we had long and short cases. In psychiatry, short case also. And we could achieve a throughput of 100 students a day, which is remarkable even for Malaysia, where high throughput is common. This 3-figure is amazing for most people. And later in January 2021, we conducted a comprehensive exam. And then we repeated it in January 2022, 2 batches, and evaluated by a top medical educationist of Malaysia from a public university. So those details and finer aspects, nuts and bolts, will be presented by Dr. Srikumar, Deputy Dean, Academic International Affairs of AIMST University, and he is my right hand in delivering clinical years content as well as evaluation. So over to you, Dr. Srikumar. After I hand it back to Dr. Mahalakshmi.
Thank you, sir. That was indeed very nice introduction. The why component we did that is was very interesting to note. We'd request Dr. Srikumar to continue the story and walk us through your ASCII stations and MiniCEX stations. Over to you, Dr. Srikumar. You are the presenter now.
Thank
So
you,
we'll
sir.
take
Thank you,
all
ma'am.
the questions together at the end, sir, if you don't mind.
Full screen, ma'am.
Yes, sir.
Thank you,
Yes,
ma'am.
sir.
Good afternoon. As continuation to sir's Mini-CEX and what we did, this is our experience when we conducted the exam, the challenges and strategies that we had to adopt. And I'll just take you through what we did and what we learned through it and what was our experiences. The actual doing of the exam. We did it twice. So when we started out, we had about 201 students. They were anxious, distressed with the restrictions imposed by the pandemic, and they and their parents were breathing down their back, worried what is going to happen to them. The most important concern at that point of time was safety. They were worried about the safety of their children, the students, the staff, strict SOPs, and we did not know what to do because hospitals were closed down. And we had the regulations, the Malaysian Medical Council and Malaysian qualification agencies with the strict control of what can be done and what should not be done. And this was always behind there, and we had to strictly follow that while accommodating all other aspects of our exams and all the other challenges too. We also had problem with venues, as Sir said, because we used to use the hospitals, the tertiary hospital at the capital city and also our district hospital, and they were closed and we could not go there. So we needed a place where we can conduct our exam with such large number of students. We also had problem with the closing because of the cases and patients. We can't get them. Nobody's willing to move. The hospital is closed. So we had issues there. And of course, as always, anything new, we had resistance to some extent, though they changed quite early. We are resistant by the students of the unknown and also by the staff, which changed. We had difficulty with examiners because we get examiners from all over the country and also Ministry of Health. There were travel restrictions, so we had problems there. And we also had an important aspect, there was time. We had to finish the curriculum within a stipulated 50 weeks. That was the time given according to MQA. And we had to also conduct the examination, and we can't hold the students for long periods. So we had time as a big constraint on our back. So these were our challenges, and I'll just quickly go through what we did, how we did, and how we managed to get through these students with 100 students being taken through the long case, short case per day. I'll just go through them. So as Sir already said, we went through the ADDIE model and we had our analysis by the Deanery, which is our Dean, Sir, and the 3 Deputy Deans, plus our principal coordinators, the preclinical, clinical, and the student relation coordinator. And we reviewed our options. When we reviewed our options, the main thing that came up was we must show that we have tested the expected outcomes. They must be assessed and we must document that, whatever process we used. As it is a high stakes examination and the MQA keeps repeating that we must show that. So we decided on trying out with a model of long case, short cases, but to go through it, we had to have a variation. So that is where Sir came up with the idea of trying to split up the Mini-CEX and use a combination of these two. So we did a hybrid adaptation. And when we did this, we also tried it out as a test and evaluation for 2 weeks on our students. So during that phase, just a quick thing as to just what Sir said, what we went through and what we did was using the essential skills. And the various stations had this, or a mix of this in the various stations. We had the interview and history taking, communication skills, organization efficiency. We also had the physical examination skills, the humanistic and professional qualities, and also, of course, reasoning and judgment. So we had all these things spread across the different cases, the long case, short cases, not just in one single case. So maybe somewhere in pediatrics, maybe some would have been done in the short case mode. So we did the whole thing, but overall, we managed to get through all the skills that is required for a houseman ready medical graduate. Just same thing as Sir said, just to remind, as Sir said, it was efficient. We really found it as doable, and we found we could organize it better here. And the same, we could get to the real world scenarios, and what's what we did, put in the real world scenarios at the show how and do level. And of course, we saved a lot of time because otherwise our examination used to be very long and tedious in the hospital. We start at 6 in the morning and end only at 6 in the evening, the 12 hours sometimes. And of course, the most important part, as has been telling, the examiners can interact with the examiners. So we had all the components and we could test all the outcomes. Now, for the regulations part, we were worried because it's a high-stake examination and we have MQMMC breathing down our backs and we have to maintain transparency at all times. So we had to ensure outcomes. We have to make sure the documentation was in place, and we also made sure, while transparency, our curriculum, what it promised to deliver, what it promised to assess, it is delivered and assessed too. So this was a statement given by the MMC that all outcomes should be achieved, and we have that all the permission and processes must be documented. They were very strict, and we were worried because we were due for our re-accreditation visit. And all the while, we had to be transparent because during the visit, they're going to go through every single page of ours, every single document. So meticulously, we had to keep up with a record of everything. And The curriculum, what we promised, should have been delivered. So the regulation said we can use only a max of 50 weeks for the year 5 curriculum at that point of time, and a 30% minimum face-to-face training. So that was the essential component we had to worry about. All put together, at one end we had our University Quality Assurance Committee and the University Senate, which is our highest body there, to help us with the permission processes and ensuring that the curriculum is delivered and assessed as required. At the other end, we had our Faculty Quality Assurance Committee and, of course, our Medical Education Unit led by our Dean, sir, and Prof. Rajesh to help us with ensuring that we test the outcomes, we have the curriculum done. The second part was resistance, though not very active, but still there was resistance as it is a high-stake examination and MMC there. We had the staff who were a bit worried whether we'll be doing the right thing. Students, the fear of unknown was very obvious to them because they were not aware of this whole process in the beginning when we announced this possibility. And of course, the regulations and again the curriculum, everywhere we have that. So staff was worried whether we are going to ensure that all outcomes are achieved and how are we going to do that? How are we going to test it with the new method? Students were anxious as to how does this work? And of course, we needed approval of AVMC later on when we submit the documentation and this completing the minimum training and delivering what we wanted. So all this was done. We had, as Sir said, we had the ADDIE model and we conducted a training program and 2 weeks of training which reduced the anxiety. The staff learned, the students also learned, and we also innovated and modified our system. In fact, the 7 minutes, as Sir said, came in after the training, and it was just right. And the faculty also had the faculty development programs which reduced the resistance and it became acceptable to all. And everybody is familiar with the whole process now. So just the 2 weeks of training, when we had that, we noticed the students really became comfortable as that uncertainty was totally gone. It just vanished and they became very comfortable and they started giving us feedback. And the lecturers also provided feedback every day as to what is happening, what was expected, how this could have been done. And that really brought us closer to our goal of testing and using the MiniCEX mode. Throughout the thing, we had a lot of issues with safety. As the parents also were worried, my child is studying there, you're putting them all together, what will happen in the crowd? I have only one child going to be infected and all these problems were there. So when they noticed our method of conducting and it is not a crowded way and we have an organized way of doing it, they too were relaxed after the children told them. So we ensured that they were safe. And of course, with what they learned, the evaluators, that is each unit, they modified their stations and checklists and they planned on appropriate timings, whether they needed 7 minutes, 14 minutes, and the 7-minute asset, and that was done. So this really helped. One of the other aspects that we told was venue. As we said, we needed examination rooms, holding rooms, examiners and staff rooms, patients. So this a lot of staff involved in this exam, and a lot of rooms which usually is available in the hospitals. When the hospital has got a lot of meeting rooms, holding rooms, we use those 2 hospitals. And the manpower, because the hospital staff, the nursing staff, the medical officers, they all chip in to help us. So a lot of their staff helps us. And so we are worried as to how things are going to run with all this. So when we usually use the on-call medical officers room, which is about 30 rooms available there. But here we needed 23 rooms in our faculty, which is close together, and another 19 rooms for short cases. We need holding rooms because we can't hold large number of students. We had to put them in smaller rooms, quarantine them, move them. And we had about 22 examiners here and 40 staff. So a lot of them moving around. And of course, we had some of those standardized patients, their relatives, and we needed them to be close enough because we can't keep them far away and stress the student. So we had to get the rooms together. And all the while, the safety aspect had to be maintained. So this close enough and safety becomes very difficult for us to manage, but we did manage by converting our entire clinical skill center, and we used the rooms across 2 floors of a building. We use the larger lecture theaters, the 300 seaters, and we use parts of corridors. We cordon them off so that we can isolate the small groups of students, and they become safe and they don't interact with each other, and neither do they have the problem of being too close and crowded. And our meeting rooms and seminar rooms, and these two were close enough, and we ensured safety. So this is how we overcome our venue shortage at that point of time, because the first time, and we were doing in our faculty building itself. The other part where we came, the examiners. The normal exam, we have a large number of examiners, 35 external examiners, plus 25 internal examiners, and there's a large number, and we had a problem here because we can't get them. So the advantage when we did the Mini-CEX mode was we could do away with those large numbers. We actually used only 12 external examiners this time. And though we had 22 examiners in all, the other 10 were from internal examiners. Because of the cascading rooms, we could manage with less numbers. When we run the long case in a hospital, for example, we do 3 sets of examiners, and each place requires more than 15 into 5. So we have a large number requirement over there. And they're, of course, they're part of our examination board, which is important for our documentation and purpose and transparency, and all of them are part of it. The other part is the manpower, which we were talking about. We have a lot of people that we needed when we brought them into our campus to do our exams. We had a large number of facilitators, as Sir said, in fact, a lot of them. We needed timekeepers on each floor, rooms. We needed examiners in each floor. We needed the logistic parts, venues and equipment, and which is all new there at that point of time. Unlike the other exam, our number of entries, we had about 2,000 sheets to be entered and rechecked, and we had confidentiality to be maintained. So we had to have a secure area for entry of marks, even though the whole building is taken up for the exam. So we had all these issues which we did manage to overcome. The last, actually, the most important part was getting cases, which we found was very difficult to get real cases from the hospital. So based on the feasibility and availability, the whole unit, in fact, all the 5 major units, the medicine, surgery, ONG, pediatric, they all came up with various methods of using different sets of patients. Some really got real patients, and we had to keep them on standby because we can't let them know early as to what is being picked up for the next day. And they had to be the standardized patients who were being trained. We had high fidelity mannequins to demonstrate some of the features. We also used videos and printed history sheets. So we used variations and combination of all these at different stations, so that all the outcomes could be tested on the mix of real patients, standardized patients, mannequins, and in fact, videos too. So just brief on our time. Usually we do it in the hospital when we have 6 in the morning till 6 in the evening, and it becomes very difficult for us. So 90 minutes long case, which is quite tedious for the students, and the short cases of 45 minutes. So we had to synchronize across 2 hospitals and stations, in fact, because we run parallel, and marking each station, each student gets 1 external plus 1 internal examiner. And the advantage there was that the number of entries only about 800 total entries that we make. So that is a less prone for errors, maybe. So when we came in with our mode, we could finish those 100 long cases in a shortest period of time, and the short cases also in a shorter period of time, much shorter than what we do. And of course, it was easy for us to do the synchronization and managing. Across the 2 floors, we could manage very easily than we did in the 2 hospitals. And the marking, the number of examiners required was less because some stations were unmanned stations and could be marked later and done. However, the only disadvantage we had was the large number of entries to be made, about 2K entries to be made within that short period of time, and we had to recheck that. But we still managed it successfully without any errors. So this is what we usually do. We have the clinical examination, long case, short case, and OSCE. This is our regular pattern of exam, where we have one long case from medicine, surgery, pediatrics, ortho, just one from either of them. The student picks up, and based on that, they get a cascade of short cases, and they also have an OSCE exam based on their postings. So when we converted to a Mini-CEX mode, we retained the same pattern, but we added psychiatry stations as a short case because the OSCE usually used to test psychiatry too, and that was not done, so we added them. So this is the actual chart we had for our long case, the real chart. So the students, when they come in, they are brought in numbers, short numbers, and they pick their lots. So based on what they pick, the lots will say M1 or S1, P1, OG1 or OR1. So once they pick for the examination period, they become M1 or S1. And this is how they move for the long case day. The M1, they move from station 1 to station 4 across. And the time duration is really, really low because they have only 1, 2, 3, 4, 5, so 35 minutes and they finish the exam. Unlike the normal day when a long case takes 90 minutes. And we are able to finish 100 before lunch. And the short cases, the same students that who had long cases medicine, so they are still referred to as medicine 1 or medicine 2. And they have a preset short cases where the medicine goes to surgery, then they move to OG, and they come back to psychiatry. So the total time that they need to spend is reduced, and they're more relaxed, and they finish early. In fact, when the first set is called in the morning, they finish by 11:39. We are finishing here. And the afternoon set, they come in by 1 o'clock, and we finish the whole set by 4. Versus the normal days when long cases and short cases used to be running from 6 o'clock. We land up at the hospital at 6:30, and we start the whole process, and we end up only by 5:30 or 6. So we really did save on time, and we did manage to go through the various stations. As Sir said, just a reminder that how we did that 7 minutes and multiples of 7. We had 4 to 5 stations here. Short cases, again shorter, and of course, psychiatry became common for all as a short case because it is usually tested during OSCE, and we took off OSCE, so we didn't want to change it, and we had to make sure that psychiatry also is tested. So we put it as a common. So we did manage to assess the skills, interview skills, communication skills, physical examination skills, humanistic professional qualities, reasoning, and clinical judgment. We used a combination, and of course, organization efficiency, as I said. We use a combination of manned and unmanned stations. Manned station, we had some internal examiners alone, some external alone, where reasoning and clinical judgment, the physical examination skills were used. Sometimes we had both internal examiners and external examiners sitting together and evaluating, and then we took an average of what they marked to make it more unbiased. This is just an example of what we have. One of the stations, just an example that just to put on how the station 1 works, and the station 2, 7 minutes. Within that 7 minutes, they demonstrate while examining the abdomen and the score sheet that we had. And everywhere we have provided comments on the students' performance so that we can tell them and improve later. And 3, we also have investigation and management, again, observe station. They also provided pictures of films, investigation, lab reports, if required, based on where it was.
Are you playing the video? We aren't getting to see. You will have to pass
Oh,
this
no.
share and take another new share.
Oh, okay.
It's not embedded, I think.
It was embedded, but I think it's not going into that. I'll go back to my. I just stop sharing and go back to the slide again. I just show this and then come back. Please.
Okay, sir.
This is what I was showing, a sample. Is this visible, ma'am, now?
Yes, sir.
Yeah, just showing how a long case, an example of a long case that was used, and the number of stations and how we went through and how they were put and the scoring done and where we had comments. When the student performed really bad or really well, they were asked to specifically comment. Otherwise, they would comment if they were deemed it was necessary. And we also provide investigations and plates and films with required on the student demands based on each concept. Just an example. So I'll go back to my. So that was the examiners and the conduct, and then the most important part, we needed to have monitoring, which has to be recorded. So we had our chief external examiner, who is a senior medical educationist in Malaysia, is Prof. Datu Raymond Azman Ali. He is a neurologist and also a medical educationist. So due to the pandemic, he did an observation through Zoom at first on day 1, and then he came in person. And then we had CCTVs all around the place where the Dato was monitoring. We were monitoring, the exam coordinators, facilitators also were monitoring. And of course, at each point, we had the movement and station facilitators who were doing a direct observation of what is happening. And finally, sirs round, he would make a round to check that everything is fine with the examination division representative. All this to ensure that everything is run fair and done as required without any other issues, and everything is transparent. Monitoring, we also had important aspects here. He checked all the documentation. We checked the questions, answer scripts, clinical cases, process. In fact, he went through everything. And then he also gave his comments about what the test was, whether the outcomes were being tested or not. Because Dato says the houseman, the student that is graduating, should be housemanship ready, not practice ready. So that's the outcome that Dato looked at. And he said that we didn't have enough to test the outcomes there. And to ensure that it's fair and there is no other event taking place, no biasing, we had multiple sets printed, and Dato would select the set for the day. And that was another issue, because those real patients have to be on standby, and we don't know whom to call and where to bring them in and keep them. So we had to manage all those aspects, keep them ready, and in a short notice, they had to be there. And he even went through all the stations when there were examiners were marking the man stations, went through the whole 7 minutes or 14 minutes there, and followed a student from station 1 to the last station to see how things work. And he gave his opinion, and that mattered a lot, because he gave all the constructive feedbacks, which did help us. That also had a meeting with all the students in private, with none of the staff present, only Dato and the students, and he interacted with them and got their feedbacks. And he was also part of our examination board. And so finally, the summary of things that we had, did we comply with the regulations despite problems? Yes, we had the multiple balance sessions, Deanery meetings, faculty board, ME unit, the quality assurance committee, Senate, all of them came in together to help us with that. Yes, we did. Hospitals, yes, we used and adapted our hospital building. We converted them, yes, we managed. Patients, based on feasibility, availability of real patients, the standardized patients, mannequins, we put all these together and we did manage to conduct the exam and test the outcomes. Manpower, yes, we had a lot of experienced volunteers who were with us with other exams and they came in, and other staff who learned and teamed up with us. Yes, we managed. Time, yes, we had synchronized, we saved time, we were more relaxed. And always resistance, yes, the FDP and assessment as learning helped the resistance from the staff and students. So we did manage to overcome the challenges and we did have our solutions and we did manage to conduct the exam. And of course, the examiner's report said that, yes, in fact, it says that we did manage, we assessed and we sequenced the Mini-CEX stations properly, and he was particularly impressed. So that was the proof of our exam process. He also met the students and said that the students were quite happy with what we did and how we managed the whole process despite the challenges of the pandemic. And that also had a chance to meet one of our international students from Chennai, and she is very happy with what we did. And so that specifically thought that it is important to mention that in this chief examiner's report. And I acknowledge, thanks to our sir for leading our team during the most difficult of times and helping us with everything. And of course, without the Deanery, the clinical units, and of course, the external examiners, the Ministry of Health and other colleges, we would not have done this properly. And of course, and our acknowledgement to Dr. Raymond for all his positive support and help. And these are some of the articles that helped us with our Mini-CEX. Thank you. Thank you, ma'am.
Yeah, thank you, Dr. Srikumar, for that very comprehensive presentation. Between yourself and Professor KRS, you took us through a very exciting journey of how actually we can do a hybrid of MiniCEX with TOSCI for actual assessment of clinical outcomes, even during the pandemic. That was indeed a very nice symposium. Sir, can we take some questions, sir, now?
Yeah, sure. Welcome.
Okay. The first question is from Dr. Sarala. How do we analyze if the students have achieved the course outcomes or program outcomes related to psychomotor and affective domain? I think that is the question from Sarala.
Dr. Srikumar, I didn't show Miller's pyramid and the evaluation. So would you like to talk about it? He has done Master's Dundee, M.Ed Dundee. So you can tell. More authentic than mine, myself. Yeah.
Oh, sir. We learned everything from sir. No, but we did use the physical examination skills were being tested. So where psychomotor was required, we did have those mannequins where they have to demonstrate on the mannequin or on the patient, and we did it based on the scenario there. So obviously, what is demonstrated on the patient will show the psychomotor aspect there. So that is what we did.
Actually, there is a hybrid hybrid model in some of the multi-station or single station for physical exam. For example, in medicine, cardiology, Professor Y.D. Singh put a standardized patient. So out of 7 minutes, the student will examine for 3 to 4 minutes, do some 2 or 3 procedures on like palpate the apex and show how you will measure pulse rate, things like that. Look at JVP and see whether it is normal or what is the pressure, etc. So some 3 or 4 you will test for 4 minutes, and then the remaining 3 minutes they are asked to give auscultate that mannequin, high fidelity mannequin where murmur, valvular lesion is depicted. So they auscultate. So the physical method is tested on a real normal standardized person, and the murmur is reproduced with a high fidelity mannequin. So together it becomes a composite assessment of the perceptual skill as well as psychomotor performance skill, and both are marked separately. Some will do the psychomotor skill, the examining patient very correctly but miss the murmur. Some will get the murmur right but miss out. These things have happened also. So that was a good question, and it was solved in a very creative manner by combining live volunteers for psychomotor and then high fidelity mannequins for the perception part. Thank you.
Thank you, sir. I think what sir was trying to say is that they assess the whole competencies rather than as skills. Okay. And there's another very interesting question from Vinuta. She wants to know how the faculty were trained to give feedback to the students.
That happened during the 2 weeks. And I said, no, we had a trial period when they were very reluctant to come. They were scared of MiniCEX as if it was some snake which is going to bite them. So we lost 2.5 months on that. In spite of Srikumar being a professional psychiatrist, he couldn't bring them to have confidence in us, our ability and calm. And then finally, after 2 months, when they saw that they're just losing time without reaching anywhere, they reluctantly moved in October, and we called them in August. And October, we did 2 to 3 weeks of this training, pilot training, where it was a formative assessment, not the summative. What he presented was summative assessment. In formative assessment, they went through long case format and short case format in small groups of 5 to 6 students circulated among these 5 specialties. And then they were shown how to examine, and on the spot feedback was given by each faculty staff. So the faculty staff learned what are the common mistakes students make, so that way they could focus on what need to be stressed, like just-in-time teaching. So they stressed more on the things that they missed out, errors of omission and commission, and skipped those which most of the students did correctly. They just passed by. Yeah.
Thank you, sir. Actually, we have worked with sir in many of the medical education projects on innovations. And it is one of the favorite things what sir does is to create faculty champions, right? Nodes of excellence within the departments who would act as resource persons for the faculty within their own specialities. We did that for ASCII champions. We did that for IQAC champions. So many faculty champions we developed, curriculum development champions and all that. So that actually helps instead of somebody from outside coming and saying that this works, if their own peers say that has much more validity. We see Senior Professor Bernard who is here. Sir, would you like to ask some comments or ask some questions?
Oh, he was the person who conducted surgery component for 2 years. Dr.
Yes,
Bernard, welcome.
Yes, with Professor Sethuraman's guidance and Dr. Srikumar's excellent management, this whole exercise went off from the training part of the students during the formative assessments and to the final summative assessments. It was real challenging and a thrill to see that how these things, the theoretical concepts, can be put into practice and made to work. And Professor Sethuraman saw where all the glitches could come, and he warned us beforehand so that the students got a smooth and error-free movement through the entire cycles of teaching, training, and final assessment. Thank you, sir. It was a wonderful learning experience for all of us, sir. Thank you.
Yeah, you are the champion for surgery department. Thank you for that.
Thank you.
Thank you.
Thank you, sir. Actually, the other thing, what ASCII many people say that it helps to assess the students, it helps faculty for formative learning of clinical skills and development of competencies as we go along. One of the important things or one of the nice things about ASCII is people watching. No, sir? Dr. KRS only has taught us. You would be watched, you will be, it is fascinating to watch how the same problem is handled by different people. So that's one of the nice things about ASCII. And I think I remember when sir used to come with us for rounds during the formative ASCII and the exit ASCII, which we used to conduct for the outgoing students. So he will point out minor things which are very fascinating to watch. That is the, what do I say, spin-off from watching ASCIIs.
Yeah, true.
Okay. Dr. Deepa is there. Deepa, would you like to summarize or ask some comments or questions?
Dr. Vijayalakshmi Lal also is there, your former
Yeah.
faculty.
Former faculty, but forever friend. Deepu, over to you.
Thank you, ma'am. Sir has explained, I feel always this little bit. I used to be confused with this ASCII, even though we had many sessions. Because in OG, how to make it in other universities, they have been using this ASCII as a formative assessment. Also, in our university, also we'll be using it. We have been using it in our clinical assessment. Yeah, whenever we have some practical sessions, in a practical viva, we have been using it. So whether one doubt which I have is whether this can completely evaluate the skills, or we have to still have more skill sessions. That's what skill assessments. What from that?
Maybe we'll ask KRS sir to take that question.
Yeah, MiniCEX, if it is creatively done, it can completely, holistically test every component of the skill. Because that was a challenge, because Malaysian Medical Council said due to COVID, 70% of study time is okay, but they didn't reduce the learning outcome. But the college must achieve 100% of the learning outcome stated in your curriculum, table of specification. So that was the challenge. So that is possible only with, could be done with ASCII, but it is very component skill testing and will need 4 or 5 rounds. Whereas in here, holistically we could test, because the examiner is free to assess. The problem in ASCII is the inspector or the station supervisor has a checklist. Often you know that Maha has been the controller. They first criticize the checklist. It doesn't have the items I want and things like that. Whereas here we have a global assessment. Below par, at par or above par. So mark from 1 to 9. So that is a global, virtually global marking. So examiner is free to go, and even the questions, Professor Bernard and Professor Y.D. Singh, who are the champions in surgery and medicine, they used to give 3 questions mandatory that every student must be asked. And depending on the remaining time available, smart ones will answer very fast. They'll have 3 or 4 minutes left. So 2 to 3 questions, depending on the knowledge level of the student, the examiner was free to assess. So they can even ask PG level questions and all that, which is not possible in ASCII. So therefore, the modified single mini station Mini-CEX is ideal, but that will take 20 to 30 minutes to do. Then what happens is you can't have a throughput of 100 students. Whereas by breaking it up like ASCII, multi-station Mini-CEX, the 25-minute or 45 minute is broken into 5 or 6 stations. So then it is possible to achieve 100 throughput in about 4 to 5 hours of time. But I am very convinced that we can do this. And even the training, that is another part. We are only talking about assessment here. Professor Y.D. Singh and Professor Bernard did a longitudinal clerkship also, which is our focus in final year, which they missed out. That on day 1, the history will be presented. That is, patient has come to outpatient, and the standardized patient will be used to examine, and the history will be either presented or a role player will actually play out the history. And that is all analyzed, and then the students will come to a tentative diagnosis and then a diagnostic plan and all that. On day 2, they'll take up the ward rounds, a bed with a standardized patient there, where this laboratory reports are presented, and just like rounds, and the whole thing is done. And third day, it will split into 3. One who recovers with the treatment started, one who got adverse reaction of some kind, third one deteriorates and all that. And the 4th day, they all get discharged, and the 5th day, Friday, will be post-discharge follow-up, prognosis, follow-up, OPD care, rehabilitation and all that. So from Monday to Friday, longitudinal clerkship was done. So cardiology in the morning means it's respiratory cases in the afternoon. Whereas Professor Bernard in surgery, they found vertical, that is morning, they'll start at 8 o'clock, that will be Monday, day 1. Then at 11 o'clock will be day 2, afternoon will be day 3, day 4, day 5, and then patient goes home. That is vertically, and the same calendar day, they will horizontally take the patient from admission to discharge. They preferred that way. They used to do 5 cases in 5 days. So like that, this creativity was welcomed. We didn't put a single thing that all of you must do like this. So they were, where ONG were comfortable with, they are always teaching with mannequin. So for them, they took it like fish to water. There was no problem at all. Obstetrics gynae using mannequins to teach. So all in all, it was a wonderful experience. And as Professor Bernard said, all the theory we learned and we teach in our entities at education workshops, these 2 years we had to actually put into practice. MiniCEX, I have learned theory long back, somewhere in the corner of my mind. But it was a revelation. Suddenly in August 2020, I realized that is a solution. Then the problem was how to accommodate 100 students. Then break it into, initially I called it chain ASCII, because staff were also new to the word, and if I put so many new things, they'll run away. So I called it a chain ASCII. I got them on board, and then later said actually it is called modified multi-station MiniCEX. And then don't say MiniCEX, and your name will, Bernard's name will be in Me Too in the evening and all that. So that way it was a humor come this thing, creative problem solving exercise done by the whole team. Thank you.
Thank you, sir. Actually, if we were to consider ASCII as snapshots of clinical competence, we are just seeing still images. This is more like short videos which make up one film, connected videos. That is what I think is the lesson. And as you always say, knowing is not enough. Actually, you should be willing, and just trying to do is not enough. You should be actually trying to be what you are trying to preach. I think that is the lesson that we take, and it was very, very inspirational, sir, this whole exercise, not only in the appropriate use of academic flexibility, which is offered by the board and the university, but also for faculty to take up innovative challenges and being really student-centric. This is what is being student-centric, not trying to give them more push marks and things like that. So thank you very much for taking us through your journey, and we hope that this would inspire other faculty also to try this in their own fields, and we'll be able to do this.
Just one last point which Srikumar forgot to mention, outcomes. 201 students appeared in 2020 December, January 2021. Except one, all others passed, 200 passed. And this time 187 appeared and 185 passed. So pass percentage is good as ASCII based exam. But it's the more robust evaluation. Thank you.
Thank you. So we thank Professor KRS and Professor Srikumar for walking us through this very interesting journey. And we'd like to thank all the participants who joined this very interesting discussions. And in our quest to go towards the 100th episode of the FFF webinar, the next week we will be again exploring a topic on trends in medical education. Now the trend is to combine education with research. So we would be having a talk on the research focus in healthcare education, opportunities and challenges for all the students. And we have Dr. Pankaj Shah, who is the professor and head Department of Community Medicine, and also the co-coordinator for the Regional Center for NMC Faculty Development at SRMC, Srihar, Chennai. He will be giving this talk on what is why there is a research focus in higher education, and what are the opportunities we can see in this, and how we can overcome challenges and induce our students to indulge more into research and foster a research mindset. So that is the talk for 99th episode, which is next week. I hope you would find time to join us on the 1st of July. Till then, stay safe. COVID is actually slowly rearing its head again. So stay safe, and we'll meet you all next week. Thank you very much. This is Dr. Mahalakshmi, Dean Health Professions Education from AVMC, signing off. Thank you, friends.
Thank you, ma'am.
Thank you,
All the
sir.
best. Bye.
Thank you, sir. Thank you, sir. Bye, ma'am.